Stand up right now, before you do anything else. Stand up from your chair and count to 10 as you do it. 1, 2, 3. Did you have to put a hand on something? Did the room feel a little far away for 2 seconds? Did you wobble, even for a moment, and then tell yourself it was nothing? If yes, what I'm about to tell you matters more than the next prescription your doctor writes. Because that dizziness when you stand up is not your age. It is not because you stood up too fast. It is not because you're dehydrated. It is your blood pressure dropping below the level your body needs to push blood up to your brain. And the most common reason it's dropping is the medication your doctor put you on to lower your blood pressure to a number that was wrong for someone your age in the first place. I'm Dr. Edward Pendergast. I'm an endocrinologist. You might be wondering why an endocrinologist is making a video about your blood pressure. Here's why. My patients walk into my office worried about their blood sugar, and most of them are also on a blood pressure medication their cardiologist prescribed without asking how their endocrine system handles it. The two systems are connected. The medication that's right for a 50-year-old with diabetes is wrong for a 70-year-old with diabetes, and almost nobody is telling you that. If you're new here, do me a favor. Subscribe to Dr. Edward Pendergast, leave a like on this video, and drop your age in the comments. Just the number, nothing else. We're working toward 10,000 subscribers, and we're building this channel on one principle. The medical system makes money when you stay sick, not when you get better. Every video on this channel teaches you to read your own body before your blood test does. Here's what I want to walk you through. By the time we get to the simple lying standing test I'll show you, you'll know whether you have this condition or not. When I show you the actual blood pressure number that recent research finds optimal for adults over 65, you'll see exactly why your doctor's target is wrong for your age. And there is one specific study from 2008, published in the New England Journal of Medicine, that almost nobody is quoting that you need to know about before your next appointment. I'm going to name the 5 things you've been telling yourself the dizziness is about. All 5 are wrong. Number 1, you stood up too fast. Number 2, you're dehydrated. Number 3, you haven't eaten yet today. Number 4, it's an inner ear thing, vertigo of some kind. Number 5, and this is the one most people land on, it's just age catching up with you. I'm going to dismantle every single one of those using the real biology of how your body keeps you upright. Then I'm going to show you the number, and then I'm going to show you what to do tonight in your own home with the blood pressure cuff your wife or your husband already owns. I'm not selling supplements. I'm not running a course. I'm not affiliated with any blood pressure cuff manufacturer. I'm an endocrinologist who got tired of watching patients fall, hit their heads, lose confidence, and stop going outside because nobody told them the medication was the problem. But to know which of those 5 wrong causes it actually is and which one isn't, you need to understand the one number your doctor isn't measuring at your appointment. Let me show you. Wrong cause number 1. I stood up too fast. This one is partially true, and that's why it's so misleading. Yes, if you stand up explosively from a deep recliner, even a healthy 30-year-old will feel a half second of lightheadedness. That's normal. The body needs about 1 full second to constrict the blood vessels in the legs and push the blood upward against gravity. But here's what your doctor's appointment doesn't have time for. In a healthy adult under 60, that half second is gone before you take your first step. By second number 2, you're steady. By second number 3, you're walking normally. If you're still dizzy at second 4, second 5, second 6, if you have to stop and grab the back of a chair, that's not standing up too fast. That is your body failing to compensate. And the reason it's failing to compensate is what we're going to look at today. Wrong cause number 2. I'm dehydrated. This one is also partially true and also misleading. Yes, dehydration lowers blood volume, which lowers blood pressure, which can cause orthostatic dizziness. That's real. But dehydration is also one of the most overdiagnosed self-explanations in seniors. If you've had a normal glass of water with breakfast and a cup of coffee and you're still dizzy on standing at 10 in the morning, you are not dehydrated. Dehydration that's severe shows up as dark urine, a dry mouth that water doesn't fix, and headache. If you've had any fluids at all in the last 12 hours and you're still wobbling, the fluid is not the issue. I had a patient, let's call her Ruth. She's 68, a retired school teacher. Ruth came to me dizzy on standing for 2 years. Her cardiologist had been steadily tightening her blood pressure medication to push her systolic, that's the top number, below 120. Every time Ruth complained about the dizziness, her cardiologist told her to drink more water. She was drinking 3 liters a day. Her urine was practically clear. The dizziness was getting worse. We're going to come back to Ruth. Wrong cause number 3. I haven't eaten yet today. The folk version of this is low blood sugar, and like the others, there is a kernel of truth here. Severely low blood sugar can absolutely cause dizziness. But for that to happen, your blood sugar has to drop below about 70 milligrams per deciliter. And in a non-diabetic adult who eats reasonable meals, that almost never happens spontaneously from skipping breakfast. If you're a diabetic on insulin, this is a real concern and you should check. If you're not on insulin and not on a sulfonylurea, that's a class of older diabetes pills that can cause hypoglycemia, then I haven't eaten is almost never the cause of your standing dizziness. The body has plenty of glycogen reserves to handle a delayed breakfast. The dizziness from skipping a meal feels different anyway. It's a gradual fade out, a feeling of being shaky, hungry, and slightly nauseous. The dizziness from blood pressure dropping when you stand is different. It's specifically tied to the moment of standing. It hits in seconds. It resolves when you sit back down. That timing pattern is the giveaway. Wrong cause number 4. It's vertigo. It's an inner ear thing. This one I take more seriously because true vertigo is real and common in seniors. Benign paroxysmal positional vertigo, BPPV, can cause dizziness on positional changes. But true vertigo has specific features that orthostatic blood pressure dizziness does not. Vertigo gives you the sensation that the room is spinning, the world is moving, you feel nauseous. It can last minutes to hours. And it's usually triggered by turning your head a specific way, not by going from sitting to standing. If your dizziness is a brief gray out, a feeling that the lights are dimming, that the room is far away for 2 or 3 seconds, that you might pass out but you don't, that is not vertigo. That is your blood pressure dropping below the level your brain needs. The fix for that is not a vertigo maneuver. The fix is examining the medication. Wrong cause number 5. It's just age catching up with me. This is the one most people land on when none of the others fit. And it's the most dangerous one because it tells you there is nothing to investigate. Here is the truth about aging and blood pressure. Yes, the cardiovascular system loses some elasticity as we age. Yes, the autonomic nervous system, the part of your nervous system that runs blood pressure without your conscious control, does become slightly less responsive in older adults. But the slowing of those reflexes does not, on its own, cause clinically significant orthostatic hypotension in someone who is otherwise healthy. The aging itself is not the cause. The medication that is working against the aging body is the cause, or the underlying disease. Heart failure, autonomic neuropathy from long-standing diabetes, dehydration from a diuretic is the cause. Aging is the substrate. Something else is the trigger. 5 wrong causes. None of them are it. Let me show you what is actually happening inside your body when you stand up. Your blood pressure is not one number. It is 2 numbers, the systolic, which is how hard your heart pushes blood out, and the diastolic, which is how hard the resting pressure stays between beats. And those 2 numbers are not constant. They change every time your body position changes. When you go from lying to sitting, from sitting to standing, gravity suddenly pulls about half a liter of blood downward into your legs. Your brain, which sits at the top of your body, briefly has less blood arriving than it needs. To prevent you from passing out, your autonomic nervous system fires within 1 second. It constricts the blood vessels in your legs and abdomen, it speeds up your heart, and it pushes the systolic blood pressure up by about 5 to 10 points within the first 30 seconds of standing. That 5 to 10 point upward bump is what keeps you steady on standing. It is the body's correction. In a healthy 30-year-old, you don't even feel it. The system fires faster than your awareness can register. But 2 things flatten that correction in adults over 60. First, the autonomic reflex itself slows down a fraction, not enough to cause trouble on its own. Second, and far more importantly, blood pressure medication, especially the medications targeted to push your sitting systolic below 120, also blunts the standing correction. The math breaks like this. If your sitting blood pressure is 145 and the medication brings it down to 120, that's a drop of 25 points. The medication doesn't care whether you're sitting or standing. It lowers it by the same amount in both positions. So when you stand up and your body tries to push it up by 10, the medication is still pulling it down by 25. The net result is that your standing blood pressure is now below 90 systolic, too low to push enough blood to your brain. That's the dizziness. That's the gray out. That's why you grab the chair. And the diagnostic threshold the medical literature uses for this is a drop of 20 points or more in your systolic or 10 points or more in your diastolic when you go from lying to standing. 20/10. Write that down. That number is called orthostatic hypotension. It is measurable, it is fixable, and almost nobody is testing for it at a routine appointment. Now you know the mechanism. The next question is, what number should your blood pressure actually be at age 65, 70, 75? Because the target your doctor is aiming for might be the wrong number for someone your age. Most doctors got this wrong. Here's why. In 2015, a trial called SPRINT was published in the New England Journal of Medicine. SPRINT followed about 9,000 adults at high cardiovascular risk and randomized them to one of two blood pressure targets. The first group was treated to a standard target, under 140 systolic. The second group was treated to a more aggressive target, under 120 systolic. SPRINT showed that the more aggressive target reduced cardiovascular events. The trial was stopped early because the lower target group did better, and almost overnight the medical guidelines shifted. By 2017, the American College of Cardiology and the American Heart Association revised their hypertension guidelines downward. The new target for most adults became under 130 systolic. For high-risk patients, even lower. That sounds straightforward, but here's what the 7-minute appointment does not have time for. The average age in SPRINT was 68. But the trial specifically excluded patients with diabetes, with prior stroke, and with institutionalized care. It excluded the frailest seniors. And while the trial included some adults in their 70s and a few in their 80s, the lower target benefit was concentrated in a younger, more robust population than the typical patient who walks into a primary care office with a hypertension diagnosis. When researchers went back and analyzed the SPRINT data more carefully, specifically looking at adults over 75, they found something the press release missed. Aggressive blood pressure lowering did reduce heart events, but it also increased acute kidney injury, syncope, which means fainting, and falls. In a population where a fall can mean a broken hip and a 1-year mortality of 20%, the trade-off is not simple. And there is one specific trial from 2008 that almost nobody is quoting. It's called HYVET, the hypertension in the very elderly trial, published in the New England Journal of Medicine. HYVET specifically studied adults aged 80 and older, 4,600 patients, 2 arms, treatment versus placebo. The target in the treatment arm was a systolic of 150, not 120, not 130. 150 systolic was the target, and at that target, treatment reduced strokes, reduced heart failure, and reduced all-cause mortality. What HYVET told the medical establishment in 2008 is that the optimal blood pressure for very elderly adults is meaningfully higher than the target for middle-aged adults. The number that the body needs to push blood through old arteries to old organs is not the number that's optimal for 45-year-olds. It is higher. Let me tell you about another patient, a 72-year-old man. Came to me because his primary care doctor had set his blood pressure target at 110/70. He had fallen 3 times in 6 months. The third fall broke his hip. He spent a month in rehab. He never fully walked the same way again. His cholesterol was fine. His sugar was fine. The only thing wrong with him was that the medication was lowering his blood pressure below the level his 72-year-old arteries could push blood up to his brain when he stood. His doctor was treating the chart, not the patient. Here is what the recent research is converging on for adults over 65 who do not have a recent heart attack or recent stroke. At 60, your target should be around 130 to 140 systolic. At 70, around 135 to 145. At 80, around 140 to 150. Higher than what your doctor probably told you. Because the biology of the older arterial system needs more pressure to do its job. The 2023 European Society of Cardiology Hypertension Guidelines have already softened to allow targets in this range for adults 65 and older. Most American doctors are still pushing toward the SPRINT under 120 target. The European guidance is closer to the truth for the population this video is for. That is the number. That is the data. That is what the 7-minute appointment doesn't have time to walk you through. You have the number, you have the mechanism. Now I want to show you exactly what to do tonight in your own home with no special equipment beyond the blood pressure cuff you probably already have in a drawer. 3 things. Write them down. Read them off the paper if you have to. First, tonight before bed, do the lying standing blood pressure test. Lie flat on your back for 5 full minutes. 5 minutes. Set a timer. Then take your blood pressure with the cuff on your upper arm, write the number down, then stand up. Wait 1 full minute. Take your blood pressure again, standing. Write that number down, then wait 2 more minutes. Take it a 3rd time, still standing. Write that number down. You now have 3 readings. Lying, 1 minute standing, 3 minutes standing. If you're standing systolic, the top number is more than 20 points lower than your lying systolic. You have measurable orthostatic hypotension. If you're standing diastolic, the bottom number is more than 10 points lower. You also have it. Either one counts. Do this test for 1 week. Same time each evening. Bring all 7 sets of readings to your next doctor's appointment. Second, the next time you go to your appointment, walk in with these 3 written questions. Hand the paper to the nurse if it'll save time. Question 1. Am I currently being targeted to a systolic blood pressure under 130 by my medication? And if so, is that the right target for someone my age? Question 2. Have I had a sit-stand blood pressure test done in your office? And if not, can we do one today? Question 3. Could my dizziness on standing be orthostatic hypotension caused by my medication, and would a dose adjustment help? 3 questions. Probably 90 seconds of the appointment. Most doctors respond well to written questions because written questions take less of the 7 minutes than verbal ones. The conversation will go differently than every other appointment you've ever had. Third, remember Ruth, the patient I told you about earlier, the 68-year-old retired school teacher who had been dizzy on standing for 2 years. After we ran the lying standing test in my office and found a 35-point drop in her systolic, her cardiologist agreed to cut her medication dose in half. The dizziness stopped in 4 days. 4 days. After 2 years of being told to drink more water. Ruth is fine. She walks her dog. She takes the stairs at her grandson's apartment. She does not hold the railing anymore. That's what the right blood pressure number looks like for a 68-year-old. Now, I want to be very clear about what this video is and what it isn't. I am giving you the information your doctor's 7-minute appointment does not have time for. I am not telling you what to do with it. I do not know your full cardiovascular history, your medications, your kidney function, or whether you've already had a stroke or heart attack. All of those things change the math. Take this video and these 3 questions to the doctor with your chart in front of him. Do not stop your blood pressure medication on your own. Adjusting blood pressure medication abruptly can cause rebound hypertension, and that can be dangerous. What I have given you is the data you need to ask the right question. What you do with the question is between you and your doctor. Your blood pressure is not your enemy. It is the body's way of making sure your brain gets the blood it needs to keep you upright, alert, and conscious. When it drops too low because of a medication chasing the wrong target, the dizziness is not aging. It is a warning, and now you know how to read it. If you watched the kidney video before this one, I owe you something. In that video, I promised the next investigation would be on your heart, specifically on why your heart races at rest after 60, which is not anxiety, which is something most doctors miss. That video is coming up next on this channel. I rescheduled it for 1 video because what I just showed you about your blood pressure was more urgent. Most of you watching this are on a medication that's affecting both your standing pressure and your heart rhythm at the same time, and the blood pressure piece had to come first. The AFib video, Racing Heart at Rest After 60, What Your Doctor is Misdiagnosing as Anxiety, is the next video on this channel. The link is in the description, and the card on screen now will take you straight to it when it goes live. I'm Dr. Edward Pendergast. I've spent 20 years watching seniors fall, hit their heads, lose confidence, and stop going outside because nobody told them the medication was the problem. Now you know. Drop your age in the comments. Tell me whether you wobbled when you stood up at the start of this video. Tell me whether you grabbed something. I read every comment on this channel, and the most asked question is the next investigation. That's the deal. I'll see you in the next video.